Good morning. Today we are going to discuss about the topic surgical anatomy of maxillary sinus. In this, we will be dealing with surgical anatomy, basic anatomy of the maxillary sinus, physiology part, and how it is clinically it is related to the oral surgery. Okay, oral surgery cases, how maxillary sinus is clinically related, and what are the various complications we encountered during surgery to the maxillary sinus, and various pathology related to the maxillary sinus. So these are the contents. So a basic anatomy about the sinus, functions of maxillary sinus, its applied anatomy, and various diseases or pathology associated with the maxillary sinus. So basically, maxillary sinus, it's the pneumatic space lodged in the body of the maxilla, and it is first described by Nathaniel Highmore, also known as antrum of Highmore. Maxillary sinus is otherwise known as antrum of Highmore, and it is in a pair, like two in number, and it is the largest paranasal hair sinus. Other sinus are maxillary sinus. Other sinus are frontal sinus, ethmoid sinus, and sphenoid sinus. And this maxillary sinus is the largest paranasal sinus, and its volume is nearly 15 to 30 ml. And its dimensions are 3.5 anteroposteriorly, height 3.2 centimeter, width is 2.5 centimeter. And it is a pyramidal in shape. That is basic anatomy. Its shape is like a pyramid and it consists of a base, apex, roof, floor, anterior wall, and the posterior wall. And the base is the lateral wall of the nose, and apex is the zygomatic process of maxilla, and the roof is the floor of orbit transversed by the infraorbital canal, and the floor is the lateral hard palate and the maxillary process. Anterior wall forms the facial surface of the maxilla, and posterior wall separates the sinus from the infratemporal and pterygopalatine fossa. And coming to the arterial supply of the maxillary sinus, the arterial supply is mainly from the external carotid artery and its branches. That is the facial artery, maxillary artery, infraorbital artery, and greater palatine artery. Venous drainage is the veins that accompany the artery. It's from the anterior facial vein and the pterygoid plexus. And nerve supply of the maxillary sinus, it's mainly the branch of the trigeminal nerve. That is the one of the branch of the trigeminal nerve. That is the maxillary branch, and other branches of trigeminal are ophthalmic and maxillary nerve. And this is the mainly these are the branches which supplies the maxilla. That is the anterior superior alveolar nerve, middle superior alveolar nerve, and the posterior superior alveolar nerve. And other branch is the greater palatine nerve. So these are the basic nerve supply of the maxilla and its maxillary sinus. Coming to the surgical importance of nerve supply, as there is a chance of the damage of nerve during the surgical procedure, and ASA because anterior superior alveolar nerve gives off from the infraorbital and about 15 mm from infraorbital foramen goes down on the anterior wall. MSA, that is the seen in the 15% of the cases arises from the lateral aspect of the infraorbital nerve. PSA, that is the posterior superior alveolar nerve, superior branch runs at the level of malar tuberosity, inferior branch run parallel to transverse facial part of the anterior nerve. Coming to the embryology, the maxillary sinus begin developing in the 3rd week of gestation, and it's the first sinus to develop. Early stages, it is high in maxilla. Laterally, it gradually grow down towards the process of pneumatization. So here, this is a table which shows the development and the age changes according to the timing. How it is, the shape is changing. That is from the 3 months to the 18 years. Once the person attains 18 years, it will become the shape of a pyramid. Otherwise, it is from tubular to ovoid, and how the growth is the changes to the pyramidal shape. Coming to the basic physiology, it is lined by the respiratory epithelium, that is mucus secreting pseudostratified ciliated columnar epithelium. Here you can see the cilia, and the lining, that is the Schneiderian membrane. Schneiderian membrane is the lining of the maxillary sinus. The basic functions of sinus, that is all sinus, is the it imparts resonance to the voice, and it increases the surface area and lightens the skull, moist and warm inspired air, and filter this debris from the inspired air, and give air padding to provide the thermal insulation to the adjacent important tissues. Coming to the radiology, it's like for the maxillary sinus, we can investigation we can do is the intraoral view and the extraoral view. Intraorally, occlusal lateral periapical lateral occlusion you can go to diagnose any pathology or any surgical related things, and extraorally, that is the most commonly for it's clearly you can see in the occipitomental or Waters view, lateral skull, submental vertex, and the CT scan or OPG. And this is the Waters view or the occipitomental view. Here we can see the both side, the sinus is there, and here in this there is a pathology. That's why it's mostly it will be radiolucent. If it is an air filled cavity, it should be radiolucent. But once when the comparing to the left side, the right side, there is a radio opacity. It seems some pathology is there in the sinus. And in this OPG, this is OPG. OPG can clearly see how the sinuses, maxillary sinus is related to the root of the maxillary molar. And in the lateral skull, this is the lateral skull view. And CT sinus we can see in the all axial or sagittal or coronal, we can nicely appreciate the maxillary sinus. Here it is a coronal view. It's the maxillary sinus, which is in the pyramidal shape below the orbit. Periapically, how it is related to the maxillary sinus, the floor, it is the lining of the floor of the sinus, how it is related to the maxillary molar. And the most advancedly, endoscopy is another investigation. We can see the maxillary sinus. Coming to the applied surgical anatomy, how it is related, as I already told, there is a relation of the root apex to the floor of the maxillary sinus, that is the maxillary molar, and the foreign body in the sinus, infections of the sinus, and another most common is the oroantral communication. How this oroantral communication, if there is a connection formed between the maxillary, once the tooth is extracted and there is a connection between your oral cavity and the maxillary sinus, there will be an oroantral communication, and some tumors associated with the sinus and implant placement. Relation, it is related to the how the root is related. Then the Ongren's line. Ongren's line is another line that is extend from the medial canthus of the eye to the angle of the mandible. Here, this line is very important because it is an imaginary line. It is significant because it determines the stage of the antral tumor. In general, if the tumor is below the line, it has a better prognosis, and if the tumor is above that, it will have a poor prognosis. Another is the pathology, that is the maxillary sinusitis. It is mainly according to the duration. Sinusitis can be classified according to duration and the presence or absence of polyps. And this is the maxillary sinus. What are the causes? Extrinsic causes are there, intrinsic causes are there. Extrinsic, there are infectious causes, non-infectious, and the disruption of the drainage. Intrinsic are genetic and acquired. Infectious, again, it can be bacterial, virus, fungus, and parasite. Non-infectious, allergic, non-allergic, disruption of the infection, trauma. And in the maxillary sinus, we can diagnose by the proper history of the patient, and then we can go for physical examination like inspection, palpation, percussion, and diagnostic technique, rhinoscopy, endoscopy. These are all the other techniques for investigation of the maxillary sinusitis. Clinical sinus, patient will be having pain, fever, and nasal stiffness. Headache will be there. Sometimes nasal discharge will be there. And the management can be mainly medical and surgical. Medical, we can advise antibiotics, mucolytic, analgesics, antihistamines, nasal spray, and hydration. And the surgical, there are sinus aspiration and cardiac procedures are there. And this is the oroanal fistula. As I already told, if there is a communication between the oral cavity and the maxillary sinus, there forms a pathological communication between the oral cavity and the maxillary sinus. Here in this picture, you can see the oroanal fistula. And the etiology can be iatrogenic, that is because of the as a clinician induced iatrogenic presence of any periapical lesion, and during trauma, during extraction, chronic infection, malignant disease. These are the various etiology of oroanal communication. And the fistula again can diagnose using the history of previous extraction, mouth mirror test, cotton whisk test, radiological IOP, OPG, etc. These are the treatment modality, how you can go for oroanal communication closure, how you can